around the eye. And it's most commonly associated with Graves' disease, but not exclusively, as it may affect thyroid eye disease, and can even occurs in euthyroid states. The prevalence of thyroid eye disease among patients with Graves' disease is up to 40%. Unfortunately, most of them are not diagnosed properly or at early stage. We can say that moderate to severe thyroid eye disease can happen in 6% of patients of Graves' disease, and sight-threatening thyroid eye disease occurs in 0.5% of these patients. Regarding the incidence, it's higher in the women than men, with a ratio of 5.3 to 1. And it has a bimodal pattern of age of diagnosis. It has two peaks of age of diagnosis in women from 40 to 45 and from 60 to 64. And it's usually 5 years later in men. We have modifiable and non-modifiable risk factors. The most important modifiable risk factor is smoking, because it increases the risk of developing thyroid eye disease very high. Also, thyroid dysfunction is a risk factor. So patients with hypothyroidism or hyperthyroidism are at more risk of developing thyroid eye disease. Radioactive iodine exposure is also a modifiable risk factor. The non-modifiable risk factors are age. With advancing age, we are at higher risk. Gender, females are much more common to have thyroid eye disease, while men are much more common to have severe form of thyroid eye disease. And family history, either to thyroid eye disease or any other autoimmune disease, is also a risk factor. Going to the pathogenesis, I will talk briefly. It all starts in the fibroblast. The fibroblast in thyroid eye disease has overexpression of TSH receptor and IGF-1 receptor. When these receptors are co-activated, the fibroblast differentiates into adipocytes, differentiates into myofibroblast, and this causes massive expansion to retroorbital area, and also starts a cytokine-induced inflammation with interleukin activation and production of glycosaminoglycans and hyaluronic acids, which are all tissue expanders. We have two phases of thyroid eye disease. The acute phase, which is the initial stage of thyroid eye disease, it usually occurs in the first 9 months, and it's characterized by active inflammation and rapid progression of symptoms. So early intervention in this phase is crucial to prevent complications and disease course. After passing by the acute phase, we go into the chronic inactive stage, in which symptoms stabilize but usually persist. Most of the treatments are not effective in the chronic phase, except teprotumumab, which is the new drug that we will talk about. Regarding the clinical picture, thyroid eye disease can present with all the symptoms of eye disease. It can present with chemosis, redness, tearing, photophobia, foreign body sensation, eyelid swelling, retraction, lack of thalamus, proptosis, which happens in 60% of cases, orbital disfigurement, and eventually visual loss. Diplopia, which is a very bothering symptom, happens in 51% of patients, muscle restriction, vision impairment, and blindness. So we have clinical grading systems, either to assess the activity or to assess the severity. And here I should say that assessment of the activity is very important for the medical treatment, while assessment of severity is much more important for the surgeons and ophthalmologists. Activity is the current inflammation and progression rate, while severity is the impact of damage caused by the disease. So we have many clinical scoring systems. I will discuss the clinical activity score, which is the most important score for activity assessment, while others, Werner classification, is a score, and European group of ophthalmopathy, of creative ophthalmopathy as a classification, I will discuss in brief. The clinical activity score, which is the best validated scoring system, it's composed of two parts. The first visit assessment score, which has 7 points: spontaneous retroorbital pain, pain or attempt upward or downward gaze, redness of eyelids, redness of conjunctiva, swelling of caruncle or plica, swelling of eyelids, swelling of conjunctiva. The patient gets 3 or more than 3 points of this system, he has an active Graves' ophthalmopathy. In the follow-up visit, which is done after 1 to 3 months, the 7 points become 10 points. And if a patient gets 4 points of these 10, he has an active Graves' ophthalmopathy. Other classification systems are Werner Nospix. And Nospix is a mnemonic for no signs or symptoms, only signs like lid retraction, soft tissue involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss. Also, the VISA classification system, which is a system for severity assessment, it assesses 4 severity parameters: vision, inflammation, strabismus, and appearance. The European Group of Graves' Orbitopathy, which classifies patients into mild, moderate to severe, and sight-threatening. And finally, Graves' ophthalmopathy quality of life questionnaire. This questionnaire depends on visual functioning and the appearance. It scores the patients from 0 to 100, where 100 is the best possible quality of life. For diagnosing thyroid eye disease, it's based mainly on the clinical diagnosis. We, of course, will ask for thyroid profile, TSH, 3T3 and 3T4, TSI, antithyroid antibodies in cases of hypothyroidism to exclude, to diagnose Hashimoto disease. The imaging, we will depend on CT, orbit, non-contrast. MRI is very important for assessment, especially in the active inflammation stage, because it assesses the fusiform rectus enlargement, orbital fat expansion, soft tissue water content, and transocular ultrasound need to be done by a highly specialized radiologist. It's a source of low cost, lack of ionizing radiation, a relatively short time of examination. For the treatment, we, of course, will discuss conservative treatment, which will be applied to all patients of Graves' ophthalmopathy, regardless of the stage. Smoking cessation is very important. Sodium restriction to reduce water retention and tissue edema. Hydration is very important to maintain proper hydration and avoid dry environments. Artificial tears, especially that contains sodium hyaluronate or carboxymethyl cellulose. Lubricating gels applied at night. Cold compresses to reduce the inflammation and swelling. Dark glasses for photophobia. Head of bed elevation to decrease the edema and retroorbital edema. And tapping of the lids for patients with lack of thalamus. It's very important to avoid corneal ulceration. After these conservative measures, what will we depend on to start treatment? We assess disease activity and severity, duration of thyroid eye disease, risk of deterioration, patient age and comorbidities, patient symptoms and quality of life, and patient preference. These are the factors that we, upon them, decide which treatment to start. For mild cases of thyroid eye disease, it has been approved in a consensus statement by American Thyroid Association and European Thyroid Association in 2022 that selenium supplementation is an important and approved treatment for these cases. Selenium has an antioxidant and immunomodulatory effects on the orbital inflammation. So it has been approved and agreed that a 6-month course of selenium, 100 microgram twice daily, is recommended for mild cases of active thyroid eye disease. When talking about surgery in mild cases, we should know that even minimal proptosis or lid retraction can negatively affect self-confidence and social functioning of some patients. So eyelid narrowing surgeries may be done in this stage. For moderate to severe thyroid eye disease, we have 4 pillars of treatment. Intravenous glucocorticoids, here we're talking about methylprednisolone, with a cumulative dose of 4.5 grams over 3 months. The course goes as follows. We start with initially half a gram weekly for 6 weeks, then follow up 0.25 gram weekly for additional 6 weeks. We should consider that we should not exceed 8 grams as a cumulative dose, and monitor for severe hepatotoxicity and, of course, complications of steroids, especially diabetes and hypertension. Rituximab is used for patients unresponsive or intolerant to IV glucocorticoids with a dosage of 1 gram intravenous, 2 doses 1 week apart. Tocilizumab indications is considered for glucocorticoid-resistant patients with a dose of 8 milligrams per kg intravenous every 4 weeks for 12 weeks in a total of 4 doses. And the new treatment, teprotumumab, which is an IGF-1 receptor monoclonal antibody. It is the newest agent applied to management of thyroid eye disease, and paradoxically, the only drug approved by FDA for treatment of patients more than 18 years. Although methylprednisolone has long been FDA approved for ocular inflammatory conditions for more than 60 years, it's not now the condition. The FDA in April 2023 released a statement that teprotumumab is indicated for treatment of thyroid eye disease regardless of activity or duration. Teprotumumab is taken as an infusion every 3 weeks for 6 months in a total of 8 doses, with the first dose being 10 milligrams per kg, followed by 20 milligrams per kg for the subsequent doses. But it has serious side effects, such as sensorineural hearing loss in 10% of patients, activation of or exacerbation of inflammatory bowel disease, hyperglycemia, and infusion reaction. So it should be taken in a specialized center. This graph by the consensus.
1 minute. 1 minute.
This graph shows that the preferred, if the indication is disease in, if the target is disease inactivation, IV glucocorticoids are the best. If patients have diplopia or proptosis, teprotumumab is the best. We cannot use it easily because it's very costly medication of a cost of $350,000 per course, which is in US 2,000 times the cost of a full course of steroids. In moderate to severe cases, we can use surgery just for inactive phase as orbital decompression, strabismus surgery, or eyelid surgery. In sight-threatening thyroid eye disease, we give intravenous glucocorticoid of 500 to 1,000 milligrams for 3 consecutive days. We can use radiotherapy cautiously in people under 35 years old to avoid long-term cancer risk, and surgical intervention, of course, in cases of orbital nerve compression, severe corneal exposure, or lobe subluxation. Thank you.